Thanks for this kind of introduction. Also, thanks for being invited to review this preemptive therapy in febrile neutropenia. This is a very important issue of special meaning at present time. Because next week is World Antimicrobial Awareness Week. Here, we like to emphasize antimicrobial because drug resistance is not limited to bacteria, not limited to antibacterial agent. Here, I would like to invite every one of you and encourage we work together to spread awareness and stop resistance. I use this slide to show the key element we promote during a national antimicrobial stewardship program sponsored by Taiwan CDC several years ago. The traditional four elements of antimicrobial stewardship will focus on drug, dose, de-escalation, and duration. However, in this program, we emphasize the first and the most important element is diagnosis. Through aggressive diagnosis approach, we identify the focus, detect the etiology, confirm the accessibility, and take into consideration of pharmacokinetic and pharmacodynamic, then facilitate the decision-making regarding the optimal drug dose, then, if necessary, the escalation. These five elements is a key element for precision medicine for individual patient to a better outcome and to secure patient safety and to avoid the potential adverse reaction. Through this approach, we accumulate. Then we have local epidemiology. Then we have opportunity to modify or develop our local guideline or policy, either national level or in your own hospital. This national guideline was prepared in conjunction with the antimicrobial stewardship program in Taiwan. This is also the first guideline among various antimicrobial guidelines in Taiwan, which focus on strategy. I think strategy is behind this key element of antimicrobial stewardship. I will explain later. Careful evaluation is needed to exclude the presence of an active invasive fungal disease, even before initiation primary prophylaxis. This requires careful history taking of the possible invasive fungal disease during prior chemotherapy and need to initiate second anti-fungal prophylaxis. In this guideline, we encourage diagnosis-driven or preemptive strategy. As for empirical therapy, we emphasize the effort of the escalation or modification. Here I explain the strategy of antifungal use. When we have no idea regarding the risk of the invasive fungal infection in a patient X, or the risk was low, and the therapeutic agent was toxic, we will initiate antifungal therapy against the confirmed after confirmation of the etiology. This is so-called definitive therapy. While epidemiology data accumulate, we identify the risk is high enough. We will initiate antifungal therapy in conjunction of the effort of diagnosis. This data was supported by the randomized control trial comparing caspofungin and liposomal amphotericin B, especially when the patient condition is critical or the limitation of conventional diagnostic methods such as culture and biopsy. When the risk is high enough and the antifungal agent was safe and have many choices, then we can consider primary prophylaxis. In recent 2 decades, in addition to classical strategy, the expert introduced preemptive therapy. This new strategy emphasized the implementation of diagnosis, either conventional culture, surveillance culture, or other surrogate marker. Preemptive therapy have 2 slightly different definitions. One is targeted prophylaxis, one is early treatment. The concept of preemptive therapy back to 3 decades ago, based on the early study regarding Gansakovil and the CMV disease. This study initiated Gansakovil therapy for CMV infection in asymptomatic BMT recipient who are high risk. That means who were seropositive or who received seropositive marrow and whose surveillance culture collected at day 30 for CMV become positive, then initiate Gansakovil for CMV infection in order to prevent symptomatic CMV disease. Based on this strategy, as you know that Gansakovil has the side effect of myelosuppress. Therefore, this study is very smartly designed so that high risk in order to targeting prophylaxis to prevent disease. However, this strategy is treatment of CMV infection. Through this effort, CMV disease decreased significantly, 3% versus 43, and the survival benefit. Therefore, the similar idea applied in fungal therapy, we call preemptive therapy. I use this picture to demonstrate after chemotherapy during high-risk period, initiate scheduled diagnosis approach. When this biomarker become positive or CT scanning has finding, may consider initiate antifungal agent preemptively. The treatment presumptively choose as definitive therapy regimen. This very famous study conducted by Roy Martin's group established the feasibility of preemptive antifungal therapy in high-risk population. Through this algorithm, they apply daily GN assay, HRCT base for high-risk event. They narrow down to treat only seropositive patient and patient with a positive microbiology test, plus supporting radiology finding, received liposomal amphotericin B. This study demonstrated the feasible of preemptive therapy, reduce the unnecessary antifungal use, and did not compromise patient safety. The second study is more practical. They conduct galactomannan test twice weekly until recovery from neutropenia. The author emphasized the result was available within 24 hours, and the positive result was confirmed with the second sample and the chest X-ray. And if chest X-ray was normal, they will conduct chest CT scanning. This randomized controlled trial compared empirical versus preemptive treatment. However, some experts apply preemptive therapy as a targeting early treatment for those have sequential PCR or galactomannan assay become positive, plus some diagnostic approach such as CT scanning, and fulfill the criteria of probable invasive fungal disease and initiate antifungal therapy, presumably as similar as specific infection. For example, galactomannan antigen positive or Aspergillus PCR positive, then will initiate a specific therapy targeting aspergillosis. Therefore, you can see this presumptive therapy have targeting for those already symptomatic. Here is the result. You can see the cumulative incidence of invasive fungal infection. Here, this is empirical therapy arm. This is a preemptive therapy arm. This is for antifungal use. This is empirical arm, and this is preemptive arm. In conclusion, in preemptive therapy arm, they use less antifungal agent, although there's more invasive fungal infection. The etiology are mainly candida. Overall, the survival was similar. Although there is some criticism or debate regarding this result, if patient receive anti-yeast prophylaxis, and you can see this study using relatively high threshold of GMAC is 1.5. The data reanalyze if for patient trigger antifungal agent using GM 0.5 and the patient receive anti-yeast prophylaxis, the number of invasive fungal disease will be similar and the survival was the same. Here is applied the PCR in diagnostic algorithm. Here is a twice weekly PCR in inpatient, and the outpatient is weekly till day 100. Show that for preemptive arm, they use more liposomal amphotericin B, although less fatal invasive fungal infection within 30 days, and a lower death rate. However, the invasive fungal infection at day 100 and the overall mortality are no difference. But very important, you can see among 12 patients in preemptive group, the majority of them start therapy early before proven invasive fungal infection criteria met. However, there's some limitation. The compliance with PCR screening, especially after discharge, are relatively poor. Here is a very important meta-analysis and a cost comparison of empirical versus preemptive antifungal strategy in hematological malignancy patients with high-risk febrile neutropenia. Here is the incidence. Here show the fiery plot of poor relative risk of invasive fungal disease detection comparing preemptive to empirical strategy. You can see the study from Australia and this study I described previously possess a more invasive fungal disease. But as I mentioned, here is mainly candida and no difference if patient receive anti-yeast prophylaxis. Here is the invasive fungal disease associated mortality, and there is no difference between these two groups. Here is the overall mortality. There's no difference between empirical versus preemptive arm. Regarding the antifungal use, the Morrissey group and the Connor group both has less use of antifungal. And we mentioned before, without compromise, their overall survival. Here is the cost comparison model. As you can anticipate that the total cost was lower in preemptive therapy arm. However, the conclusion might vary in different countries because the antifungal agent, the cost of antifungal agent or the diagnosis may vary by different countries. Overall, in 2000, the experts suggest instead of universal prophylaxis or empirical therapy, they suggest a targeting risk-based antifungal strategy. For those very high risk, it is rational to adopt prophylaxis strategy. For those low risk, it is highly recommend preemptive therapy or even targeted therapy. More and more effort is emphasized that universal antifungal therapy is not needed in patients with persistent febrile neutropenia. And this is a tailored diagnosis and therapeutic approach was recommended. For those with persistent febrile neutropenia, more than 4 days, here is emphasized, in addition to risk, we need to pay attention to the severity of the bedside condition. For those with severe sepsis, septic shock, we need to collect the blood culture immediately and initiate empirical antifungal therapy, either using caspofungin or liposomal amphotericin B. On the other hand, for those hemodynamically stable, we need clinical evaluation and initiate some diagnosis to evaluate the etiology and focus of fever. Then based on this diagnosis approach to initiate, this is so-called preemptive therapy, preemptive strategy. This comprehensive recommendation from German's group emphasize that when we're facing a patient with fever and neutropenia, we initiate antibacterial therapy. At the same time, we do some diagnosis approach. Based on the clinical course and the result of diagnosis approach, we consider the continue or discontinue antibacterial therapy, modification, or escalate for additional antifungal therapy, either targeting or preemptive. Here, I would like to emphasize that patient might be febrile, especially in severely immunocompromised or with organ failure, especially in the elderly population. The wait for night, it may be febrile. On the other hand, wait for 4 days may delay antifungal therapy empirically for those with prior fever unknown of origin, which respond to antifungal therapy. That is the potential presence of invasive fungal disease without confirmation. Here is the preemptive strategy, demonstrate the diagnosis-driven approach, emphasize aggressive diagnosis and the timely result. Optimally, in the same day, including blood testing, CT scanning. In addition, the bronchoscopy is available. and feasible and tolerable by the patient. And based on the CT finding and the blood testing and others to determine whether initiate anti-fungal therapy. Here, the right-hand side, I would like to pay attention to the right-hand side. Here, CT normal screening negative could rule out invasive fungal disease. Are you feel comfortable regarding to this suggestion? I will show a clinical case, quite challenging case. Here is the 37-year-old gentleman with a very complexity underlying disease and very difficult to treat and remain refractory leukemia. He received a serious myelosuppressive and immunosuppression therapy. He remained neutropenia and a febrile with aggressive diagnosis approach. Here, SE means serum galactamine antigen twice weekly. All these results were negative. However, a mold, Acrimonia species, was isolated from a nasal swab surveillance culture collected on October 9. This is last month. Although he had received image study, including PET scanning, chest HRCT, two days later, he complained of epistaxis and then right cheek pain. The CT scanning for head and neck did not show any definite lesion. However, the symptom persisted. Therefore, ENT doctor conduct cystoscopy examination and showed the right maxillary sinus has some lesion, some ulcer and cluster. Then take the biopsy and send culture. The culture, again, here is a histopathology. After the procedure, patient feel better. There's the less facial pain and normal rhinorrhea. However, the attending physician hematologist quite concerned the ENT finding and asked for ID consultation for opinion regarding the antifungal agent modification or others. Here is the histopathology provided later. Here is HE stain. You can see the arrow and the arrowhead. There's a hyphae in the acute angle and 90-degree angle branch. Here's the GMS stain. Here is the acute angle. Here is the right angle branch. Here's the adventitious sporulation. All this picture, according histopathology report, is compatible with acrimonium or fusarium and others. Because the fungi, we test the MIC, the azo MIC within resistant range, and B MIC was very high, up to 4. We initiate combination therapy using the voriconazole and the liposomal amphotericin B. However, you can see the C-reactive protein increase gradually and the fever persist despite of very aggressive combination therapy. And in October 21st, we repeat the culture and one set of blood culture collected from pole A group sample fungal culture. The preliminary report, the lab informed the primary care physician that there's a yeast-like organism isolated from the blood culture. The time to positive of 4 days. Can you guess what the possible etiology regarding this breakthrough yeast-like organism? We consult the lab specialist, Dr. Huang, immediately and follow the blood culture. You can see the morning finding is the yeast, but 6 hours later, you can see the high feed. The final diagnosis is Fusarium. We collect the isolate and conduct the MIC. All MIC are very high. Okay, we back to our previous experience. This published several years ago. This is a disseminating fusariosis in a patient with cutaneous T-cell lymphoma with acute leukemic change. This young gentleman is a refractory. You can see this is a refractory, complete remission, refractory again. And the fusarium was confirmed from the specimen collected from oral thrush, cutaneous disseminated lesion, extremity, face, and the blood culture. It's the same situation that the MIC are very high, and at that time we aggressively using the combination therapy, including voriconazole and the liposome, and titrate the voric dose by TDM, and this gentleman survived temporarily. However, he passed away due to the refractory leukemia. Here are summarized the pros and cons and limitations of preemptive therapy. Through this diagnosis-driven approach, we can target it to etiology based on the biomarker. We can treat those in need, likely to be hemodynamic, but at low or intermediate risk, and minimize overuse of antifungal agent. However, there's a slightly different definition, and this approach needs dedicated team of clinician, radiology, microbiologists as well. Then we need to consider the tolerability of intensive monitoring, especially after discharge from the hospital. We also, the key issue will be the logistic and cost of diagnosis. In addition, we need to take into consider of the clinical performance of diagnosis, which may vary by patient population and local epidemiology. In addition, the issue of false negative and false positive should be considered. Therefore, physicians need to take into account other information. Regarding the risk of withdrawal or delayed treatment in select scenarios through cross-observation and based on renal control trials show that there is no difference in survival and length of hospital stay. We have some experience regarding the false cross-reactivity of this biomarker and the false positive regarding the IVIG. I will explain in the next slide. Here is the experience regarding the false positive GM-assay associated with IVIG. Here is the saline, maltose, and different concentration of IVIG. You can see the GM index up to 4, very high. However, through sequential cross-monitor of GM assay, our data demonstrate there's some difference regarding the true positive versus those false positive due to IVIG. Therefore, sequential testing are important, as emphasized from the initial study mentioned that 2 consequent sequential GM assay more than 0.5 are more specific for the diagnosis of invasive fungal infection or trigger antifungal agent use. Regarding empirical strategy, is symptomatic-driven approach. Treat all without missing anyone, especially when medical information is optimal. We can intervene during golden time for moderate or critical ill patient and or patient at high risk while waiting for the result of diagnostic testing, especially when the access to diagnostic tests are limited during long holiday or weekend. Of course, we need to emphasize reassessment and de-escalating antifungal to offset the drawback of this symptom-driven. However, we need to keep in mind the patient may be a febrile. In addition, while we widely use may over-treat, there are uncertainty regarding duration of therapy or necessity of second prophylaxis and others. In conclusion, how to determine the optimal antifungal strategy, individualized or in your specific patient population or in your hospital. In our national guideline, we emphasize we need to consider the following factors, such as epidemiology or individual risk, diagnosis to in-facility, accessibility to healthcare setting during high-risk period when patient discharged from the hospital, the therapeutic factor, and the cost effectiveness. The decision to start prophylaxis or empirical use of the drug is a low-hanging fruit. However, one size not fit all. Besides, there emerge resistance in commonly used antifungal agents. Decision-driven diagnosis approach are hampered by clinical performance of single test, delay in available result, and tolerability of the procedure at that time. On the other hand, preemptive approach, that is a scheduled periodic surveillance during high-risk period, before appearance of symptom sign, facilitate select the optimal agent and dose. In the absence of aforementioned diagnosis approach, it is difficult for the decision to modify or de-escalate antifungal agent, when to discontinue use of drug, or secondary prophylaxis in future immunosuppression therapy, or Antimicrobial Awareness Week. Thank you for your attention. Please stay safe and healthy in the context of ongoing COVID-19. And welcome to Taiwan. In the future, we can have the face-to-face meeting and others.
Hi, Professor Chen. Good to see you again. Thank you very much once again
Good to
for
see you,
the talk.
and thank you for invitation.
Yes, thank you very much. Yes, and while we are awaiting question, to share some thoughts, I always think that antifungal stewardship is actually a moving target, and it is on a slightly different ball game with antibacterial ASP. And the reason being is that it's a moving target because antifungal stewardship is heavily dependent on platform availability, technology. You can see that a lot of it is actually heavily driven by fungal diagnostics, be it the POC kits, turnaround time, or even using the T2 system, for instance. So heavily driven by technology, costs, and even simple things like turnaround of the CT scan or turnaround of your galactomannan, beta-glucan, and its availability. So of course the question is that, given that much of this experience of antifungal stewardship actually originates from, from the West, how do you think are the challenges that will be faced by countries in Asia, especially in the setting of resource limitation, in executing antifungal stewardship?
Thank you for Professor Tsai for very important question and very difficult question. When we consider implement new technology or platform, I think it is a medical need. However, we need to go back to very traditional microbiology platform. As I mentioned, in our very difficult to treat challenging case, the information is there. Acrimonian or Fusarium. Therefore, we need to mobilize the resource, what we have in your hospital, integrate together in order to improve the quality of care instead of waiting for novel biomarker or those not visible in your daily practice. Although we need to work together, as Professor Chavagati, he will give a talk in the following section. We'll more focus on this challenge in Asia country. We need to work together to more crosstalk between physician and the microbiologists in the lab, as well as working together to improve the whole quality based on the resource we have in Asia country.
All right. Thank you very much, Professor Chen, and we look forward to catching up with you again in person. Thank you very much for the very enlightening talk.